shoulder, you all know, is an unconstrained joint, and that makes it so particular because that's what is very special about it. It's that most of the stability of this joint is completely dynamic. It comes from the muscles, and so when these muscles do not work anymore, well, the joint does not work anymore at all, and it's really typical of that joint. Then you all know that it's made of several parts, several joints, but the two main joints that compose the shoulder joint is the glenohumeral joint that accounts for 70% of the motion approximately, and the scapulothoracic joint. And it's very complex because 14 muscles move and most importantly stabilize the shoulder. And without the muscles, the shoulder is completely unstable and is non-functional. And so there are 8 muscles for the glenohumeral joint specifically. Most of them are the rotator cuff muscles and the deltoid. And then you have 6 muscles that move the scapulothoracic articulation. And most importantly, the trapezius and the serratus anterior. All these muscles can be combined in functional units, and they have a certain role in the shoulder movement. And so, depending on which muscles are non-functional, which muscles are concerned by paralysis or by chronic tear, then you're going to have different deficits. And so, if you look at this patient, for example, this patient is a brachial plexus patient from Bassem El Hassan, and you can see that he has absolutely no motion. He has no active deltoid, he has no active cuff, and so his shoulder cannot elevate, cannot rotate, and cannot move at all. Now, when we look at this more typical patient, you can see that he has very nice deltoids on both sides, but when you ask him to elevate the arm, well, he can lift his left arm with no problem, but the right one, the deltoid contracts, but the shoulder is not stable anymore. It's not functional anymore. There is an anterior subluxation of the head because there is no active rotator cuff muscles. He has nice rotations, you can see, but he has no elevation. He has an imbalance in the vertical plane, and we're going to talk about this a little bit later. Then you can see this patient, which is quite surprising, but it's quite typical also. You can see on the right side, he has a very nice deltoid, and on the left side, you can see there is no anterior deltoid, but if you look all around him, he's a little bit chubby, so it's difficult to see, but he has no deltoid at all. He has a complete chronic axillary palsy. And although he has a complete palsy of the deltoid, you would expect him not to move his shoulder, but since the shoulder joint is completely stable and stabilized by the rotator cuff, he can do almost every shoulder motion except shoulder extension, as we could just see right now, because that's the only motion that is specific of the deltoid muscle, especially the posterior deltoid. But the rest, the function of his shoulder is quite normal. So you can see that depending on which muscles are impaired, then you're going to have different paralysis, different function. Then if we talk about biomechanics, we need to concentrate on basic notions and basic principles, and something that we need to keep in mind is the center of rotation, because essentially the movements that the shoulder is going to make are movements of rotation. So every time there is a movement of rotation, we need to find the center of rotation. And what point is the center of rotation? The center of rotation is the point that does not move during a rotation. So if you look at that triangle, it rotates around the O point, and that point does not move during that rotation. So that's the center of rotation. Then another, so if we look at this on the shoulder during abduction, for example, you can see that you have the black dot that is the center of rotation. And if you go through abduction, you can see that this black dot does not move because that's the center of rotation of the joint during abduction. If you look at other motions, then if you look at anterior flexion or if you look at axial rotation, maybe the center of rotation is going to be different. The center of rotation in the shoulder can move because this joint is non-constrained, and so the movements are not only rotation, but there is also some translation. So when there is going to be translation, the center of rotation is going to move, and then it's going to be stabilized by the cuff, and once it's stabilized, then you can have a movement of rotation. But you really need that rotator cuff for stability. because it's unconstrained. That's what's important. Then the moment arm, it's something that we hear a lot about when we talk about reverse shoulder arthroplasty. So we need to understand clearly what the moment arm is. And so the definition of the moment arm is the distance between the line of action and the center of rotation. So if we look at that bolt, if you want to unscrew that bolt, you can use your hands. And so the line of action is going to be this arrow. And so the moment arm is going to be the distance between the center of rotation and that line of action. But now if you have a longer moment arm, then you can very easily understand that the strength required to unscrew that bolt is going to be much less. And so if you want to increase the moment arm, you can use a tool like a wrench, for example, and then the moment arm becomes this distance from the center of rotation going to the line of action. And you can understand very intuitively, very easily, that the strength required to perform the same movement is going to be much less. And there's something important with this definition is that for a joint, for example, for the elbow, if you look at the brachialis that is represented here in red, you have the center of rotation here in yellow of that elbow joint. And you can see that this line between the distance between the line of action and the center of rotation for the same muscle, for a same joint is going to be modified during the movement of flexion, as the center of rotation is going to move closer or further from the line of action of the muscle. That moment arm can vary during motion. So that's something to keep in mind when we study moment arms around the shoulder. So then if we go back to how the shoulder works, most movements that are important for us is movements of rotation. What we want to do is rotate the arm around a center of rotation to do abduction, elevation, or axial rotation. In order for this rotation to happen, you need to neutralize the translation. And so how do you neutralize the translation? Well, the supraspinatus, the subscapularis, the infraspinatus, and the teres minor are all going to compress the head against the glenoid in order for the center of rotation to be in a fixed position. Once the center of rotation is in a fixed position, then the deltoid can work, and the deltoid can do a nice rotation movement around the center of rotation. Okay, so the rotator cuff, we think always of the rotator cuff as a means to do some rotation, because the infraspinatus and the teres minor does external rotation, the subscapularis does internal rotation, but the rotator cuff is also very importantly a stabilizer of the joint. And this is why in some cases we have some pseudo-paralytic shoulders, because the shoulder is not stable enough. So this is something that had been described by Steve Burkhardt a while ago, is the force couple. And you can see when you look at the shoulder that we have two force couples. One is a horizontal force couple and one is a vertical force couple. And if we look at these two force couples, if we look at the shoulder from above, we can see that in the front, there's the the subscapularis, sorry. And in the back, there is the posterior cuff with the infraspinatus and the teres minor. And these two muscles, they are opposite, and they create a horizontal couple. The same way, if we look at the shoulder from the front, we can see that there is the deltoid pulling the shoulder over superiorly, and the rotator cuff is pulling the head towards the glenoid, is opposing against that superior force. And so there is also a vertical force couple. And so when there is imbalance, when there is disruption of one of these force couples, well, the shoulder becomes non-functional in either the vertical or the horizontal plane, or sometimes in both. And so we can have an imbalance of the shoulder. You can see that it's imbalanced because it's no longer centered. You can see that the head is not in front of the glenoid anymore. So there is some sort of imbalance. But since this imbalance has taken place over many years, the shoulder has become fixed against the acromion. It's a Hamada 4B shoulder. So it's against the acromion right now. And so now there is no more translation because the shoulder has transformed itself into a constrained joint. And so it doesn't need anymore the rotator cuff for stability, because it has stability from the acromion and from the coracoacromial arch. And so despite this radiological aspect that is very severe, well, this patient is has a balanced shoulder because she has managed to balance her shoulder herself without the muscles, but by modifying the bony architecture of her shoulder. But in other cases, when you can have some imbalance, and you can see this patient, it's a patient from Philippe, she has a very weak supraspinatus, a very weak infraspinatus, but the rest of the cuff is fine. So it's not a very severe imbalance, and you can see that she can lift her arm if she is helped with the other arm. And when the arm is up, she can lift it, but she cannot lift the arm on her own because the shoulder is not perfectly balanced. And so in this situation, this is what Pascal Boileau has called painful loss of active elevation or painful shoulder. It's a functional shoulder, but it's a painful shoulder because of irreparable rotator cuff tear of the infraspinatus and the supraspinatus. But the shoulder is still functioning, but because you can see that the inferior subscapularis and the teres minor are still intact, and these two are enough to maintain the vertical balance against the deltoid. And so when these two muscles are intact, usually there is not a complete imbalance of the shoulder. But you can have a complete vertical imbalance if the inferior subscapularis is completely irreparable, or if the teres minor is completely irreparable. Well, you can see this patient, it's like the gentleman that we saw in the beginning. She has anterior subluxation of the head. She's trying to elevate the head, but she has a loss of the vertical couple. And so she has nice axial rotations because the horizontal couple is fine, but she has a loss of the vertical couple. So this is what we call a pseudo-paralytic shoulder. Typically, the shoulder is not very painful, but it's not functional. We can have also a loss of the force couple in the horizontal plane, and this can concern either the posterior cuff, like this gentleman who has no more posterior cuff, no more infraspinatus, no more teres minor. You can see he's trying to do some external rotation, but he has a negative external rotation with the arm on the side. And he's trying to put the hand to the mouth, and he has what we call a hornblower sign because he has no more active external rotation. Why does he have no more active external rotation? Because he has no more posterior cuff, but the internal rotators are still intact, the subscapularis, the latissimus dorsi, the teres major, and the pectoralis major. They all work, and they are not counterbalanced by any more muscle. This patient, this is a more rare presentation where he has a complete loss of internal rotation, isolated because of an irreparable subscapularis tear. So it's the opposite as the gentleman we saw just before. He has nice forward elevation. He has nice function in the vertical plane, but he has loss of internal rotation. These imbalances can be combined, and they can be combined in both the vertical and the horizontal plane. And you can see this gentleman on the left. He has lost his vertical balance because he has no more anterior elevation. He's trying to elevate the arm, but he's pseudo-paralytic. You can see that the joint is perfectly supple. He has full passive range of motion, but he has no more active elevation, and he has no more active external rotation. He cannot put the hand to the mouth anymore, and he cannot do external rotation. This is what we call the combined loss of elevation and external rotation. Some people also believe that it can happen in the other direction with the loss of elevation and internal rotation, and this is what we call the combined loss of elevation and internal rotation. Now, if we focus on that vertical imbalance, because we're here to talk about reverse shoulder arthroplasty and not tendon transfers today, and if you have a full vertical imbalance, if you have a superior migration of the head, it can end in a cuff tear arthropathy. These patients, we used to treat them with a Hemi 30 years ago. but this surgery gave satisfactory results on pain because we replaced the damaged cartilage, but the function was terrible because the shoulder was not stable because the rotator cuff was non-functioning. So how can we treat these patients? Well, you all know now that in 1985, Paul Gramont had a brilliant idea. He had the idea to modify completely the anatomy of the joint and the biomechanics of the joint, especially of the glenohumeral joint, in order to restore function in a pseudo-paralytic shoulder. And so now you're going to understand very easily the principles that make this reverse shoulder arthroplasty work. The first one is the medialization of the center of rotation. So the medialization of center of rotation, now you understand perfectly what the center of rotation is. You can see on graph A, this is the center of rotation of a normal shoulder. And you can see on graph C that the center of rotation has been modified. How do you modify that center of rotation? By modifying the shape of the shoulder. Instead of being a ball on the humeral side and a cup on the glenoid side, it's the opposite. You have a ball on the glenoid side and a cup on the humeral side, and that makes the center of rotation much more medialized. And what is the consequence of that? Because medializing the center of rotation is nice, but we don't really care. What we care is that it's going to increase the moment arm. Just as we saw before with the bolt and the wrench, you can see that this distance here, it's the distance, it's the moment arm, because it's the distance between the line of action of the deltoid and the center of rotation. So it's the moment arm of the deltoid. And you can see that this distance is increased when you medialize the center of rotation, which is quite logical. You move the center of rotation away from the line of action. So you increase the distance between the center of rotation and the line of action. And so what does this do? If you increase the moment arm, well, the deltoid is going to have to do less effort to create the same movement. So that's the first principle that helps the reverse shoulder arthroplasty to work. The second one is the distalization of the humerus. Why is it important? Because often in these cases, you have a superior migration of the head. So you have a relaxation of the deltoid. And so if you distalize the humerus, you can see here the greater tuberosity is quite close to the acromion. But with the reverse shoulder arthroplasty, you can see that the distance between the greater tuberosity and the acromion is much more. By doing that, we push away the deltoid insertion from the acromion, and this is going to increase the tension of the deltoid fibers. And if you tension the deltoid fibers, they're going to be more prompt to fire when the patient is going to want to do some anterior flexion. So that's the second principle. Another very important principle, you have seen the lady which had who had the severe cuff tear arthropathy, but with perfect range of motion. This lady, she had perfect range of motion despite no cuff, because she had transformed her joint from a semi-constrained joint to from a non-constrained joint, sorry, to a semi-constrained joint. And so this is what Gramont thought. He thought if we transform the joint from a non-constrained joint into a semi-constrained joint, well, the translation forces are going to disappear, because if you pull on the semi-constrained, on an unconstrained joint, if you pull on this yellow arrow, you're going to pull the head away from the glenoid. And then maybe if the cuff contracts, you can have some rotation. But if you have a constrained joint, as you can see here, well, if you pull on one side or the other, the only movement that's going to take place is rotation. So there is no more translation, no more parasitic movements, only effective rotation. So all the force that is going to be applied on the joint is going to transform into rotation. And then the last principle was to medialize completely the center of rotation, also in order to position it at the junction between the bone and the implant. You can see here the center of rotation is at the interface between the glenoid and the base plate, and this is going to decrease the stress on the implant, is going to decrease the shear forces, and so it decreases the risk of glenoid loosening. And so all these four principles make a perfectly functioning reverse shoulder arthroplasty, and with a mean 130 degrees of elevation, with a nice abduction. But this was not completely perfect, because if you medialize a lot, then there can be some impingement between the medial part of the humerus and the scapula, and this can create scapular notching, and we can see scapular notching that can progress and eventually reach that screw and loosen completely the glenoid. That's a possibility. If you have scapular notching, you're going also to have impingement between the polyethylene here and the bone or the metal. This can create some polyethylene wear with debris. This can lead to osteolysis of the glenoid, of the humerus, and to resorption of the bone. So scapular notching is an important complication. If we medialize a lot, we can have poor improvement in axial rotation, in external rotation, and in internal rotation, because there can be some mechanical impingement between the bone and the scapula. And also because if you medialize a lot, then we're going to relax the remaining rotator cuff, the subscapularis, and the infraspinatus. Then what is possible also, if you medialize a lot, all the soft tissues are going to be relaxed. You're going to lose some compressive forces of the deltoid. You're going to have relaxation of the remaining rotator cuff, and this can lead to instability. And then the last problem, if you medialize a lot, then the patients, they can be a little bit disappointed with the shape of their shoulder, because since the joint is so much pushed into the body, you can have the contour of the shoulder that becomes a little bit abnormal. So in order to correct this, three surgeons had the idea to modify slightly the design from Paul Gramont and to lateralize. And we've been talking about lateralization since 2003 now, because of the ideas of Philippe Valenti, Marc Frankel, and Pascal Boileau. But this lateralization is something not very clear, because it can happen on both the glenoid side and also the humeral side. And it can happen on the glenoid side and on the humeral side by modifying different aspects of the implant. So we need to focus on every single modification to understand the implications. If we look at the glenoid, you can see these are three different designs of glenoids, of lateralized glenoids, but they lateralize differently. You can see that the base plate here, it lateralizes by being what we call onlay. It means that the glenosphere, instead of being completely flush to the bone, it is there is a distance between the bone and the glenoid that is the thickness of the base plate. So instead of being around the base plate, it is above the base plate. So you have the thickness of the base plate, which lateralizes a little bit the glenoid part. You can also modify the shape of the sphere. You can see here it's half of a sphere, here it's half of a sphere, and here it's 2/3 of a sphere. So by modifying the shape of the sphere, you modify also the lateral offset, because you lateralize a little bit the glenoid part. Or if you think that metal is not a good option to lateralize, you can keep exactly the same design as your usual glenoid, but you can lateralize by adding some bone here. And what you do in reality is that you modify the shape of the scapular neck, you modify the anatomy of the neck in order to lateralize the joint. You can also lateralize in the humerus, okay? You can lateralize on both sides. And how can you lateralize on the humerus? You can modify the shape of the stem. This is the typical delta stem that has been designed by Paul Gramont. And now this is a completely straight stem. And now most stems you will see, you will notice, have a curved shape. And if you have a curved shape, then you're going to push the lateral part of the humerus, the greater tuberosity and the rotator cuff attachments, away from the glenoid. So you're going to lateralize on the humerus. You can also lateralize on the humerus by modifying the neck shaft angle. Initially, Gramont proposed a 155 degrees neck shaft angle, but you can modify that to 145 or even 135 degrees. And this lateralizes a little bit, we will see maybe later. And then you can also modify the shape of the humeral liner or the humeral insert. You can see here that in the Gramont design, it is what we call an inlay stem, sorry. It's inlay because we have to ream the metaphyseal part of the humerus to put this part inside the humerus. But with this type of implant, the humeral cut is here. You don't have to ream the metaphysis, but you place an implant above the humeral cut. And so you're going to preserve some metaphyseal bone because you don't have to do some reaming of the metaphyseal bone. But on the other side, you're going to distalize and lateralize on the humerus. So you have to keep in mind that all the implants on the market have different designs. They have chosen to modify certain aspects of the implant and not others. And it's important to understand the type of implant you're using because this lateralization can have some consequences. So whether you lateralize on the humerus or on the glenoid side, it's going to be a global lateralization, and global lateralization has some common effects. But if you lateralize on the glenoid side or on the humeral side, it's going to be slightly different. It has different implications. So if we look specifically at the glenoid side, if you lateralize on the glenoid, you can see very clearly on this drawing that you're going to push the humerus away from the scapula. And so you're going to decrease scapular notching. What you're going to do also, you're going to limit and decrease impingement-free range of motion because there is going to be less mechanical impingement between the humerus and the scapula on this side. But as you push away the center of rotation, you push the center of rotation and you bring it closer to the line of action of the deltoid. So if you do that, you're going to decrease the moment arm of the deltoid that we saw in the beginning. You may also increase the stress on the acromion if you lateralize a little bit too much. And you can increase the shear forces because we saw that it was important to have the center of rotation at the interface between the implant and the bone. If you push away that center of rotation too much, you can have some shear forces on the scapular neck, on the glenoid, and you can have glenoid loosening. Although now you can see that we can have very strong hardware fixation, and this problem is not a problem anymore too much with lateralizing glenoid implants. Now, if we look at the humeral lateralization, we can see that it restores a more anatomical position of the humerus because you're going to push the greater tuberosity and the lesser tuberosity more to an anatomical position than with a Grammont design. And by doing that, you're going to increase the compressive forces on the joint. So you're going to improve stability of the joint. You're also going to push away the line of action of the muscle away from the center of rotation. And now you've understood that if you push the line of action of the muscle away from the center of rotation, then you're going to increase the moment arm or the lever arm of the deltoid. And you can also increase what we call the deltoid wrapping angle, although we don't really know if this wrapping angle is very important or not, but you can see here that if you have a medialized implant, your deltoid is going to have a very straight line of action. But if you lateralize on your humeral side, well, you're going to push your greater tuberosity away from your scapula. And so the deltoid is going to have a more anatomical angle. But then as soon as you go to 30 degrees of abduction, this is no longer true anymore. This is why we can discuss the importance of this wrapping angle. But if we want to summarize now the biomechanics of the reverse, well, it's now very clear that reverse shoulder arthroplasty restores forward elevation in case of vertical imbalance of the shoulder. And it restores the forward elevation in case of vertical imbalance, but it is the only solution to restore forward elevation in case of vertical imbalance for chronic vertical imbalance, for chronic pseudo-paralytic shoulder. If you medialize too much, you can have some disadvantages. We've seen that on rotation, on the aesthetic of the shoulder, and on scapular notching. So it may be important to lateralize in both parts. Glenoid lateralization is necessary to reduce scapular notching. Maybe modification of the neck shaft angle also is necessary to reduce scapular notching too, and also to improve impingement-free range of motion. Some amount of humeral lateralization is probably necessary to restore a more anatomical position of the greater tuberosity and of the lesser tuberosity. But as soon as we lateralize, we need to be careful not to lateralize too much, especially in smaller patients, because the risk is overstuffing of the joint. And so what is important is to adapt your technique and also your implant to the type of patients you have and to the morphology of the shoulder. And so I think Philippe is going to be pretty clear about this, because he's going to show you how he plans a reverse shoulder arthroplasty and also his technique to implant a reverse shoulder arthroplasty. Thanks a lot for your attention.
Thank you very much for your invitation. I try to be very practical, and I show you what we do now when we have to do a reverse shoulder arthroplasty. This is my disclosure. This is the outline of this lecture. It's important to remember the indications in cuff tear arthropathy, because I think that if the indication is not good, the technique is not good. Tips and tricks on the results that we have now, because learning curve is very important with the reverse shoulder arthroplasty. So if we talk about irreparable cuff tear, the definition of a pseudoparatic shoulder is when there is anterior and superior migration of the humeral head. Sometimes it's static, sometimes it's dynamic, and I think that is very important to remember the definition, because many surgeons talk about pseudoparatic with a forward elevation of 100 degrees, but it's not pseudoparatic. Pseudoparatic is static sometimes when the humeral head is just under the skin, and sometimes is dynamic, like this patient with a superior and anterior escape of the humeral head. So regarding the X-ray, you see this is a very, very bad X-ray with a osteolysis of the acromion, and this is a Amada 5, and sometimes there is no arthritis, but eccentric head, Amada 3, and this is an indication of shoulder arthroplasty, reverse. This is another case. For example, you see a very big atrophy of the muscle, infraspinatus and supraspinatus. You have a superior migration of the humeral head. You have no arthritis. This is a pseudoparatic shoulder, and this is a good indication of reverse. And I would like to show you this case, because this is a swelling shoulder, very painful, and you see a osteolysis of the acromion and osteolysis of the humeral head. And it's very important to remember that this is an emergency case, because if you wait 3 or 6 months, you have sometimes a resorption of the superior part of the glenoid, and after it will be very difficult to implant the base plate. So when you see this kind of patient, I think that we have to operate as soon as possible. Sometimes you do a mistake because you have a massive cuff tear and you did acromioplasty on AC ligament, you cut AC ligament. It's a bad way because you have a superior migration of the humeral head just under the skin with a paratic shoulder. And you see these X-rays. When you do a reverse arthroplasty, it's very, very difficult because you see that the distance here between the definitive position of the reverse arthroplasty is 5 or 7 centimeters. And many times you have a risk of axillary palsy or radial palsy. And when I have this kind of patient, when I do a deltopectoral approach, systematically I do a neurolysis of the axillary nerve and radial nerve sometimes, but axillary nerve, I do a neurolysis because I am afraid about the risk of brachial plexus palsy. I have a case a long time ago, a very little woman, 40 kilo, with this kind of deformity. And postoperatively, I was very happy regarding the X-ray, but the patient had a complete palsy of the brachial plexus. She recovers partially in 18 months, and it was a catastrophic result. And it's a reason why we contraindication of arthroplasty when you have a massive cuff tear. The last situation, if and Jean-David talked very well regarding the vertical and horizontal imbalance. For this patient, you see that there is a lack of active forward elevation, but there is a lack of active external rotation. There is a lag sign, there is a drop sign, and you see that on the MRI, there is a complete atrophy on fatty infiltration of supraspinatus, infraspinatus on teres minor. And it's an evidence that if you do only a reverse arthroplasty, you don't restore any external rotation. And in this kind of patient, you have to combine episcopal procedure, latissimus dorsi or latissimus dorsi plus teres major around the humerus. So when we decide to do a reverse arthroplasty, it's very important to do a preoperative planification, particularly for the glenoid. And you know that this classification of FABA, this E0, E1, E2, E3, there is a superior erosion of the glenoid. And this is very important to identify this deformity, because if you don't do a superior bone graft, you have a superior tilt and you have a glenoid loosening. And it's very, very important to measure the deformity of the superior part of the glenoid. The second point is the classification of Gilles Valch, and this is the last classification with a type D with a anterior instability. And it's very important to identify that, because many times the subscapularis is deficiency, and there is a deficiency of the subscapularis. And if you do anatomic arthroplasty because you think that there is not a big deformity, the posterior superior cuff is correct, and you have a risk of rupture of the subscapularis. And type D is an indication of reverse arthroplasty. So you have to identify B2 and B3. There is in this case, there is a big subluxation of the humeral head in B1, B2, B3, and C, there is a posterior subluxation of the humeral head. And you know very well that if you do anatomic arthroplasty, many times you have a recurrent subluxation of the humeral head, and you have a risk of glenoid loosening or posterior polyethylene wear. So many times in type C and type B3, even the patient is young, we decide to do a reverse arthroplasty. So after, what do? I do systematically standard X-rays. I do a CT scan, and I ask for the radiologist to do a 3D reconstruction. But now we develop a software like IMASCAP or software. Many companies has a software now. But in FH Orthopaedics, we develop a software eOrtho, and you have you send the CT scan 2D to the engineering of FH Orthopaedic, and he does automatically a segmentation, and he sends you a 3D reconstruction of your patient. And it's important to evaluate the bone deformity, but it's very important to evaluate the soft tissue. And for us, it's very important to evaluate the teres minor for the external rotation, but subscapularis also is very important for the strength in medial rotation. And with the CT scan on T1, you can evaluate the soft tissue and you can evaluate the bone deformity. So if you do a standard X-rays, this is very important that you see that you can measure two angles. This angle TSA was developed by the team of Gerber, and this is a deformity of the global glenoid. And it's very important to know this angle when you do anatomic arthroplasty to evaluate the inclination of the glenoid. But when you do a reverse arthroplasty, the most important is to put your base plate flush to the inferior part of the glenoid. And many times it's not your base plate, the design of the base plate is very small, and you have to evaluate the deformity of the inferior part of the glenoid. And it's the reason why Pascal Boileau described RSA angle is completely different, is more important than the TSA angle. And in my practice, it's very important to evaluate the deformity with the RSA angle, and with the software, the engineering measures the inclination of the surface of the base plate. It's the reason why when we compare many software, there is a little difference, because if you measure the deformity of TSA and if you compare to RSA, it's completely different. It's the reason why sometimes the software are different. Regarding the retroversion, you can measure, but it's not very precise, the Friedman angle. And regarding the subluxation, the posterior subluxation, you can measure with axillary view and with index DE, and if it's most 55%, there is a posterior subluxation. If it's less, 45% is the anterior subluxation. So I think that is important to measure that, but this measure we can obtain automatically with the new software. On a 2D CT scan, because 5 years ago we tried to evaluate the deformity on 2D CT scan in a free plane, sagittal plane, horizontal plane, and coronal plane. And now we use a software, and the software does automatically the measure of the retroversion, the measure of the inclination, and the measure of the posterior, the subluxation of the humeral head. And this is a system, and it's important to remember that in Imaescape, they do automatically 3 points at the level of the glenoid, medial part of the spine, and inferior angle of the scapula. And with eOrtho, this is an engineering who shows these 3 points, and is important because it shows a point here, not here, but it's very important to choose a good point, and they evaluate the deformity for the RSA in the inferior part of the glenoid, because this is the future positioning of your base plate, and this is a future positioning of your guide, and it's very important to remember that. And you can measure the inclination and retroversion. I show you a case. This is a man, 65 years old. There is a stiff and painful shoulder. You see that 90 forward active elevation, external rotation is very painful. You see that the value of the pain on the shoulder function is 30%, and the constant score is 32. This is the X-rays, standard X-rays. You see that there is arthritis, there is a medialization, there is a posterior subluxation here, and you have to do a CT scan. And you see that on the CT scan, you can see that there is a B2 on the B2 on the posterior subluxation. There is a superior migration, and the quality of the muscle is not so bad, but there is an atrophy of the supraspinatus and the fatty infiltration. So this is the software. I can show you the software. This is the automatic reconstruction. On the left side, you have 2 planes, 2D. On the right side, you have a 3D reconstruction. You can remove the humerus if you want, and you can evaluate the glenoid. And you see that the version, the native version is 8 retroversion. The native inclination is 11, and there is 54% of posterior subluxation. And after you choose your implant, if you decide to do a reverse arthroplasty, you see that you have a guide, and it's important to correct the retroversion and the inclination. And you can choose a guide to obtain 0 degree of retroversion. This is a sitting. You can measure the sitting of the base plate here. There is a mistake, and you can control with the horizontal plane, and you can measure the vault of the glenoid. You can move the implant to obtain a good positioning. It's very important that. And you see that. On the right side, you can measure the distance between the inferior part of the glenoid and the center of the base plate. And you see that if you use a guide 10 degrees, you correct the retroversion to 4 degrees is correct. And the inclination, you use 20 degrees to obtain an implant with 11 inferior tilt. And you see that when you modify the rotation of the base plate, you modify the version on the inclination. It's very important to understand that because it's 3D space. And you see that the setting of the prosthesis is 50% is enough in this prosthesis because there is a good price fit with the anterior winglet on the keel. And you can evaluate the bones that you have to graft superiorly. You see that. In this prosthesis, I prefer to do inferior tilt to medialize a little the prosthesis because it's too much lateralization in some patients. And this is a glenosphere. You can choose 36 or 48. And at the end, when you are very happy regarding the positioning of your implant, and you can choose the screw. This is a cortical screw, and you have to perforate the cortical bone to obtain a good fixation of the screw. And you can choose the screw as you want. And at the end of the planification, you have a summarize of your implant. You save it, and you go to the operating room with that. This is the guide. You see that you will use a guide with 10 degrees for correct the retroversion and 20 degrees in inclination. Here, inclination version. So, before I want to summarize what is very important, because whatever your implant, whatever your software, whatever your material, your ancillary system, I think that we have to respect academic rules when you implant a reverse. The first question is how much you do the retroversion. And for us now, we try to reproduce the anatomy. If the retroversion of the humerus is 20 degrees, we put 20 degrees of retroversion of the humerus stem. The most important is to have a good alignment with the glenosphere. The second point is a base plate. For us, the recommendation is not a superior tilt, never, because there is a risk of glenoid loosening. Inferior tilt is good, between 5 to 10 degrees. And most important is to put flush the inferior part of the glenoid to avoid a glenoid notch. Regarding the lateralization, you know that the lateralization is important to increase the strength of the muscle for external rotation. If you medialize too much, you relax the muscles, and it's not good for external rotation. It's important to have a lateralization. Regarding the distalization, I think that it's important to increase the fibers, the tension of the fibers of the deltoid, and to increase the strength of the deltoid. And It's very important to adapt the positioning of your implant, depends on the morphotype of the patient. If you have a big patient with a strong deltoid, it's not necessary to distalize a lot. The most important is to lateralize, to stabilize the shoulder and to restore external rotation. If you have a patient very thin, 40 kilo, many times we have to distalize more than to lateralize, because if you lateralize too much, as described by GD, you overstuff, and the patient is very painful with a risk of bursitis of the deltoid. And the key point, whatever your prosthesis, you have to adapt the position, the lateralization, the distalization of your prosthesis depends on the morphotype. If I want to summarize, and this is a practical experience, because we have no data to prove that, but in our experience that if the patient is thin, not to lateralize too much, but distalize, if the patient is strong, there is no problem. You can lateralize, no distalization too much. So this is a technique I show you, 7 minutes. And I use a deltopectoral approach systematically. I stay lateral to the coracoid process because it's very important to have a good exposition of the glenoid. And I use a deltopectoral approach. I try to respect the cephalic vein, and I put laterally the cephalic vein many times. It's very important to find the triangular space at the top of the deltopectoral here. There is a little soft tissue and you have it in a good plane. So you have to do a good release of the deep part of the deltoid. You have be careful inferiorly, and after I protect the deltoid with a compress like that. And my first step is to do a tenodesis of the biceps at the superior part of the pectoralis major. This is the first step. The second step is to do hemostasis of the circumflex artery. It's very important. And you define the superior part of the subscapularis and you detach it. And the inferior limit is the latissimus dorsi. And you have to detach the subscapularis with the capsule, and you have to detach very, very far to 9 o'clock on the humerus to obtain a good release. You see, it's very, very important. Detach the capsule and the subscapularis, very large. The latissimus dorsi is the limit of the inferior part of the subscapularis. And after you use a reamer, we use a long stem to avoid varus and valgus. It's not a problem. And after, the most important is to define your cut of the humerus. And there is we use a guide because I think that it's very useful to determine the retroversion with a good alignment between the rod and the forearm. And for the level of the cut, this is an onlay system. We have to remove a little more bones than inlay system. And we use a pin at the superior part, which is flush to the great tuberosity. And we have two positioning for anatomic on reverse. And we cut a little more bone on reverse because this is an onlay system. Okay. And after you put your stem, and we protect the superior part of the humerus. And after we do an exposition of the glenoid, we use four retractors, retractors posteriorly, retractors anteriorly, retractors superiorly, and retractors inferiorly. I think that you have to do a large capsulectomy. You resect the labrum and you define very well the glenoid. And you see that I measure the distance between the center of the base plate and the inferior part of the glenoid is 16 millimeters when we use a 44. And for the reverse, I don't use the big, but I use a smaller one. And the distance between, and we reproduce the preoperative planification. And I try. This is a very small glenoid in this case. I reproduce the distance inferiorly and superiorly. And after I use a guide and I put a Kirchner wire, when the position of your Kirchner wire is good, the operation is finished. You remove cartilage, and after you follow your Kirchner wire, and you remove all the cartilage, and you prepare the keel. You have inferior tilt, and you will put a bone graft superiorly to obtain inferior tilt. I prepare the keel, and you see that the most important is the direction of the Kirchner wire. The direction is a good correction of the inclination on the version, and after you follow your Kirchner wire, it's very, very comfortable. And after you prepare the keel, and you have a space superiorly, and you have to put the cancellous bone graft between the glenoid and the back of the base plate. I do a small holes to increase the potential fixation of the base plate. I put the cancellous bone graft superiorly from the head. You see that you have a bone graft. And after we have a good price fit of the prosthesis. And we impact the prosthesis. And without screw, you see that we have a good fixation on the bone graft. And we did a CT scan systematically, and we have a 100% of healing of the bone. And I lock inferiorly first, and second superiorly, and I put the glenosphere. I impact the glenosphere and I screw the glenosphere into the base plate. So the last time is to repair the subscapularis, and for us it's very, very important to repair the subscapularis. And we do a double row repair. If you use a peeling technique, it's possible to medullarize a little your repair of the subscapularis. It's a reason why I prefer the peeling technique than tenotomy. And I prefer peeling technique than osteotomy because you fragilize the metaphyseal part. Bone graft is better than any cement. We don't use any cement except for osteoporotic bone, and we impact and we do the, and after we reduce, it's very stable. You test in abduction, in adduction, and you do the double repair of the subscapularis, medial repair, and lateral repair, transversus repair. And it's very important for us, not for the stability, because the most important is for internal rotation and the strength in internal rotation. I think that we have to repair anatomically the subscapularis. You see that this is the second row, this is a transversus repair. And at the end of the operation, you have to obtain 30 degrees of external rotation. It's very important. If you have no 30 degrees of external rotation, you have, my recommendation is not to repair the subscapularis. So you repair anatomically, you see that? Okay. Okay, you check the external rotation. So this is the X-rays. You see that there is a lateralization, there is an inferior tilt, good fixation, there is no risk of glenoid notch. So very quick, because if you have any question, I review my last cases of 121 reverse in curved arthropathy with more 2 years follow-up. And this is between 14 to 18, mean age is 73 and 44 months. And we have 86 cases of first operation, and previous operation was cuff repair or tenotomy of the biceps or arthroplasty. So regarding the result, you see that we can obtain 130 degrees of forward elevation, good external rotation, and the constant score is around 64. And the function of the shoulder is 80%, and the constant score on the pain is 2. and 80% of the patients are very, very, very happy, and only 5% were disaffected. So regarding the complication is viscera, it's the reason why I think that the learning curve is very important, because I was surprised that only 3 complications in viscera, 1 mechanical dismounting, 1 humeral loosening, and 1 infection, and no scapular notch and no problem of healing of the cancellous bone. So this is an example. You see that this is good lateralization, good distalization. There is no risk of glenoid notch, and there is an inferior tilt with a good compression of the bone. So with this position, we have less instability. We have a better shoulder contour. Of course, you see that this is a good deltoid, and this is a better external rotation or no notch. So this is my first case. It's very, I was very happy to see her, because it was my first case in 2003, and we use when you analyze 15 years ago, the positioning of the prosthesis is not very different. That now we understand better. Now it was a positioning with the feeling a long time ago, but now we didn't change a lot. But it's interesting to understand better. So if you have no active external rotation, you have to combine with episcopo, and we did, and you see that the rate of episcopo in the global series is 8%. Is not a lot. And for us, the indication if drop sign, lag sign, and atrophic of the teres minor is very important on fatty infiltration. Of course, we exclude it if you have deltoid palsy, because you have to combine with a pectoralis major flip flap or stiff shoulder. But if you have a patient with external rotation in position 0, in position 1, 0 degree, we prefer not to do with tendon transfer, because with lateralization, we can obtain a good external rotation. Regarding the technique, is a technique classical, and we use 2 tendon, and you fix the opposite of the insertion, not too much to anterior, but lateral and posterior, and you fix latissimus dorsi and more posteriorly the teres major. Now I don't continue to use both, but I use only the latissimus dorsi, and I didn't check my patient, but my feeling is the same result. And you see that in this series we restore systematically active external rotation. The constant score is better, 75. I don't understand that, but if you compare with the classical reverse and reverse episcopo, the constant score is better. And regarding the function of the shoulder is the same, 70%. And it's more interesting is to compare the group with 2 5 years follow-up and 5 to 12 follow-up. And there is no significant difference regarding external rotation. But you see that the active forward elevation is less with a long follow-up. We don't understand why, but when you analyze a patient with a long follow-up, we have less strength regarding the deltoid, but the patient keep a good external rotation. This is a case, for example, here with restoration of external rotation on good elevation. So the conclusion that if you have a cuff tear arthropathy with irreparable posterior superior cuff tear or no subscapularis, we have a pseudoparetic shoulder. And if you want to restore active forward elevation, you can do a reverse shoulder arthroplasty. Lateralized reverse prosthesis, I think that is a good way because you restore more external rotation and you have less glenoid notch as described by GD if you lateralize the glenosphere and more external rotation. And it's very interesting to follow the patient because with more than 10 years follow-up, if we compare the survival rate of reverse arthroplasty with anatomic arthroplasty, we have less complications in reverse arthroplasty. And the key question now is when you have a patient of 75 years old with a functional cuff or with a supraspinatus tear but a good infraspinatus, what are you doing? Do you continue to do anatomic arthroplasty? And you know that after 10 years there is a risk of revision. The patient will be 85 years old, or do you decide to do a reverse arthroplasty because you are able to repair the subscapularis, you keep the infraspinatus and the teres minor? I think in the future, maybe we have to change the indications, depends of the rate of complication. And now my way is after 75 years old or even the cuff is functional, I try to do reverse arthroplasty and I keep the cuff. And I am very happy regarding the long follow-up of this kind of patients. I would like to thank you a lot.